Good evening. We have in our midst Dr. Tadid Mohanty, MD in Medicine and Critical Care from the SV Medical College, Bhubaneswar. We welcome you to Natco Pharma Specialty Studio this evening. And we would love to hear your opinion, your say in the space of critical care associated with antibacterial resistance. What, as per you, have been the changes that you have seen or observed in the critical care management?
Over the years, we have seen that we used to start with, say, very modest antibiotics, but slowly, after using it unnecessarily and without any, say, control over our own what we are going to prescribe, we don't know what we are going to prescribe. So people go on prescribing uh, uh, a lot of antibiotics without requirements. So we have to prevent that resistance. We have to use wherever it is required. And as for a local antibiogram, we have to use. And people just left and right go on writing the antibiotics. So this carbapenemase resistance has developed over the time. It was not immediate. So when there was no stewardship in antibiotic, nowadays we have got this stewardship, and we have been doing all these things in our rounds. What the people are, and the infection control department should be there, and it's all like the nurse, the consultant, the infection control team, everybody should work together, and then only we can overcome this resistance.
Thank you so much for bringing up that point. What is your advice to the young ICU doctors so that they can enhance patient care better?
So they should all over they should know how to prevent the infection and the resistance. And suppose the patient is already infected, have come from outside, then you should go on the community acquired that that protocol has to be there. But if the person is multi-resistant, so they have to change the antibiotic according to, first you send the culture within an hour, and within an hour you start the empirical antibiotic as for your antibiogram, and awaiting the culture report, they then go on changing the antibiotic. Suppose you are getting carbapenem resistance, then accordingly what your culture comes, then you go. Nowadays, when we started with meropenem or penems, so it was used left and right. So when there was, say, first then came, we used only ertapenem to just give it a rest to the to the antibiotic resistance species. So then it rose, and people went on using it. And now we're into the different spectrum of antibiotics now, and the different spectrum of organisms like Acinetobacter, and so many new organisms have come up. So now we have come to the newer antibiotics.
Dr. Mohanty, my last question to you is what is the prevalence of carbapenemase producing bacteria in your practice?
It must be around 20 to 25%.
And what treatment options do you look at?
We have several options, like we go on giving avivectin added, and then we go on giving what's called say several other newer antibiotics, like I just cannot remember all those, but newer antibiotics, we have gone through all the newer antibiotics.
So, with us this evening is Dr. Mohanty, and we thank you so much for spending your valuable time with us. Thank you on behalf of Natco Pharma Specialty.